Hello everyone, welcome back to the YouTube channel, and today we will be talking about sonographic marker of fetal chromosomal defects. In this presentation, we will discuss the sonographic marker used to detect chromosomal abnormalities. There are four methods that we will be discussing here. Several diagnostic and screening methods are available. These include amniocentesis, which involves the sampling of the amniotic fluid, chorionic villus sampling, also known as the CVS, where placental tissue is obtained in early pregnancy, and the third one is cordocentesis, which involves sampling fetal blood from umbilical cord. Although these invasive methods provide definitive diagnosis, but they carry a risk to the pregnancy. Therefore, ultrasound examination plays a vital role as non-invasive screening tool for early detection of chromosomal defects. Here we will be talking about sonographic markers. Ultrasound allows us to identify several markers that may indicate fetal chromosomal abnormalities. Most important sonographic markers include nuchal translucency, the presence or absence of the nasal bone, the size of the nasal bone, and biochemical markers, which are used alongside ultrasound findings. These markers are mainly assessed during the first trimester and help identify fetus at increased risk of the aneuploidy. The fourth slide is about nuchal translucency. Nuchal translucency, or NT, refers to the fluid-filled space at the back of the fetal neck. NT is measured between 11 and 14 weeks of gestation, when the crown rump length, also known as CRL, is between 45 to 84 millimeters. The measurement should be taken in the mid-sagittal section of the fetus. The maximum thickness of the black space between the soft tissue overlying the cervical spine and the skin is measured, as this area represents the nuchal translucency. In this slide, we will be talking about the technique of measuring NT. Accurate technique is essential for reliable NT measurement. During the scan, more than one measurement should be taken and the largest one should be recorded. The measurement should not be averaged. The calipers must be placed correctly with the horizontal line positioned on the inner border of the nuchal translucency space. As you can see in the figure, the calipers should not be placed on the skin line or within the fluid itself. Is incorrect place, as incorrect placement can lead to the inaccurate result. Here we will discuss the nasal bone. The nasal bone is another important sonographic marker. Both the presence or the absence and the measurement of the nasal bone are assessed. To visualize the nasal bone, a mid-sagittal view of the fetal profile is obtained. The image should not be zoomed so that only the head and upper thorax are visible. The transducers should be angled at approximately 45 degrees to the forehead chin line. In normal fetus, three distinct lines are seen. Two parallel lines represent the skin and the nasal bone, while the third line shows the higher line. The third line is the higher line, which represents the tip of the nose. Here we will be talking about crown rump length, or the CRL. Low birth weight is a common feature in many chromosomal abnormalities. Severe intrauterine growth restriction, or IUGR, is often linked to aneuploidy. Growth patterns vary between chromosomal conditions. Triploidy, which involves an extra set of chromosomes, shows distinct growth abnormality. Trisomy 18 or diploidy are associated with moderate to severe growth restriction, while trisomy 13 or Turner syndrome typically show mild growth restriction. In contrast, trisomy 21 usually shows normal early growth. Since nearly 30% of pregnancies have uncertain dates, ultrasound measurements of CRL is used for accurate dating. Importantly, correcting gestational age does not affect screening result for the trisomy 21. Next is about fetal heart rate. Fetal heart rate also provides useful information. The fetal heart rate rises from approximately 110 bpm at 5 weeks to about 170 bpm at 9 weeks, then gradually decrease to around 150 bpm by 14 weeks. The early rise reflects the rapid cardiac development, while the later fall is due to parasympathetic nervous system maturation. Certain chromosomal abnormalities are associated with abnormal heart rates. Tachycardia is commonly seen in trisomy 13 and the Turner syndrome, while bradycardia is associated with trisomy 18 and triploidy. A mild increase in heart rate may be seen in trisomy 21. Here is the last slide, which is about fetal Doppler. Doppler studies provide additional information about fetal circulation. In the umbilical artery, studies between 11 and 14 weeks have shown that around 50% of the trisomy 21 fetuses may have an increased pulsatility index (PI), although findings are inconsistent. The umbilical vein is normally non-pulsatile except during fetal breathing movements. Pulsatility in the umbilical vein suggests fetal compromise. Between 11 and 14 weeks, approximately 90% of the trisomy 13 and trisomy 18 fetuses show umbilical vein pulsatility, while trisomy 21 fetuses appear similar to the normal ones. The ductus venosus carries oxygenated blood to the fetal heart and shows a waveform with S, D, and A waves. In absent or reversed A wave is seen in 60 to 90% of abnormal fetuses compared to about 5% of the normal fetus. Doppler assessment is therefore used as a secondary screening tool alongside anti-measurement and serum marker. That's it for today. The remaining important information will be discussed in the next lecture. Subscribe to the YouTube channel for more updates and informative videos. Thank you.